women's health pre-pregnancy, women's health during pregnancy, and women's health after pregnancy should really matter. We're not even doing enough to identify these risk factors that could change health during pregnancy and the outcome of that pregnancy, including the child's long-term health, let alone care about the woman's health after the pregnancy. So I think, it's a real call to redefine what do we even think of when we say women's health. Hello, everybody. Welcome to HERology, a podcast from Mount Sinai Health System and the Carolyn Rowan Center for Women's Health and Wellness, where we advance women's health by bringing together science and the stories that shape women's health in our lives every day. My name is Anna Barbieri. I am a practicing gynecologist with a tiny bit of a burning passion for women's hormones. And today we're talking about a topic that's important to actually all of us. Whether you're a woman or you know a woman, I think you're going to care about it. The topic for today is what we do not know about women's health, how that comes across in clinical care for women, what are the research gaps, and what can we all do about that? And I'm joined today by my two amazing co-hosts. So co-host number one is the woman that does it all, everyone. This is Dr. Joanne Stone. She is our chair of the Department of Obstetrics, Gynecology, and Reproductive Science. She is a practicing maternal fetal medicine physician and obstetrician, and she does research. I don't know how she does it all, but she does. And also Dr. Leslee Shaw. And Dr. Shaw is the researcher extraordinaire. She is the director of the Blavatnik Family Center for Women's Health Research, and she's got decades of experience in women's health research with an amazing perspective on its historical aspects, its current challenges, and future outlook. Welcome.
Thank you so much for having us.
Great to be here.
Yeah,
it's going to be fun. All right. So, as a practicing physician, literally every day I come across things we really don't know. And it creates quite a bit of uncertainty, actually. We know so much more today than we knew 40 years ago even, and yet there is still so much we do not. Every day I'm asked questions by patients that I don't have an answer for, and I think that is part of medicine that is quite normal. I think it is important to kind of face the reality that there are just things that are beyond the limit of our scientific knowledge. But there's also some systemic reasons for that. And I'm curious, Dr. Stone, what sort of things do you come across in your clinical practice that you wish you had answers for?
Oh gosh, such a good question, and there's almost everything. I mean, we do have some answers, but there's so much more that we need to understand, and research is the way of getting those answers. There's a patient that we have on our service right now who's 21 weeks pregnant and has severe what we call fetal growth restriction, where the fetus is just not growing properly. So why did it happen? Well, she had a whole workup. We can't really find anything. Her placental function is not optimal by any means. Her genetics are normal. So number one, why did this develop in her? And how do we treat it? Because we don't really have any good treatments for this. So that's a huge, that's fetal growth restriction that could lead to stillbirth, things like that is a huge area of research that we need to focus on that we don't have all the answers to.
I agree. It's such a difficult situation, too. Why did it happen? What do we do now? And will this happen again if she has another baby in the future? Just one example of what we face all the time. Certainly, I don't practice obstetrics anymore. I have been there and done that. I face a lot of these questions in women who are coming to see me for hormonal health issues, things that honestly affect 50% of the population, and yet still there's so many gaps. Why do some women get premenstrual depression? Why do some women get postpartum depression? Why do some women have terrible mood symptoms in their perimenopausal transition? Clearly, it's linked to hormones, and we don't quite understand why that is. Why are we so different in terms of our response, for example, to hormone therapy? And why? I was thinking about this actually last night at 3 a.m. why can't we sleep past about the age of 40 or 45? So we're scratching at the surface at those things, but not quite there in terms of knowing the answers. And I think knowing these answers would change outcomes and health of so many women out there. So, Dr. Shaw, you're the person with the answers today. Why is it that we still have so many gaps in our knowledge?
Well, first of all, I think medicine is just like society. There's a tremendous amount of bias against women. We're not in positions of power, so we're not always the priority. And that's something you should say right off the top. It hasn't been a priority for the NIH. It hasn't been a priority for funding agency. But also, I think, and you look at drug development, you look at device development, women are smaller than men generally. And so a lot of those anatomic differences, and I use size, but it could be a lot of things, are not taken into consideration. There's such a speed to develop drug or device development, particularly if I talk about anatomics, I'm talking about devices that are built for a man and then put them into a woman and you say, oh my gosh, they have complications. I can't figure that out. Oh, you put a hip that's devised for a 180-pound man and you put it into a 120-pound woman and surprise, surprise, she has complications.
I mean, that's shocking, right? That's like a woman buying size 11 men's shoes and trying to run a marathon.
100%,
right? Like that's the equivalent.
100%. And I also just think that medicine itself is so siloed, right? And we don't connect those dots because there's so much to learn in being a gynecologist or being an MFM and, or being a liver specialist or being whatever it is. You don't make those connections across the specialties. You talked about hormones and menopause. That is something where the implications and what happens that occurs are amazingly far-reaching. Osteoporosis, and cardiovascular disease, Alzheimer's. You can go on. And name the specialists that actually can pinpoint all of those. And there isn't one. So there hasn't been this attention, and even when there has been attention, it's been a lot of lip service. Now we're having a lot of resurgent interest from the NIH, but look at the institute, one of the institutes of health that is dedicated to women's health, NICHD. How much of is it really funded in terms of obstetrics and gynecology? I think it's like 1%. It's really small. So think about that. And the institute that I apply for, National Institute of Heart, Lung, and Blood, I mean, they've had a few dedicated projects for women. Are you kidding me? Out of a $3 billion a year budget, a couple of projects that maybe total to $10 million. And then you say, I think we've done pretty well given how much we have, and how much care we've given. But, we just actually not only have to have that information, we have to have our listeners demand that information. We have to set standards that we want that are really going to close those gaps.
I just wanted to follow up, and I've said this before in other talks, but when you mentioned NICHD, funding women's health research, that's what we apply to get research grants. But it's National Institute of Child Health and Development. Child Health and Development. Where does that say women's health research? Where is that about menopause? Where is that about complications from pregnancy? It's not. I mean, so that's like a huge problem.
Well, I think you kind of have hit the nail on the head there, and I think we could be here for many hours discussing this topic, but I think that actually has to do with how society has viewed women to this point as vessels of fertility. And that is why we have this Institute for Child Health Development that women's health is rolled into, because we are the gender that gets pregnant and gives birth. But our health is a lot more than pregnancy. I know, Dr. Stone, you focus on pregnancy, so that's very, very important. But we are more than just our fertility potential. And the other thing is, in a lot of the funding statistics, sometimes roll in breast cancer, which we do have a lot of tries, a lot of attention to. But again, our health extends beyond that. So when you look at the statistics beyond breast cancer funding and beyond child health and development funding, that data is again, to me, it's shocking how little gets spent on that. Going back to the issue of fragmented care, there is also this perception again that women's health centers on reproductive issues, and all of us here are part of the Department of Obstetrics and Gynecology, and we're actually trying to expand that lens Take an example of an older woman who may have very frequent urinary tract infections. It is a major issue for older women who end up seeing either urgent care or perhaps a urologist or infectious disease specialist and get treated with multiple antibiotics, leading to antibiotic resistance later on, ever more expensive drugs that need to be used. Sometimes they need to be admitted to the hospital for something as simple as a UTI. And the dot with menopause, actually, and certain menopause-induced changes and consequences are not addressed, where something as simple as vaginal estrogen could have prevented that. So to me, that is a daily example of what I see in practice when it comes to these gaps. Where do we go from here? Dr. Shaw, what are some things today that are happening to, or not happening, to address this?
I think the whole issues of where the NIH is right now has led all of us to be a little bit more inventive and to get more of the limited resources we have. And I think it's forced us in meaningful ways is to go across specialty, not just for clinical care, which you see here at the Rowan Center, which is part of what we're all working on, where it's multi-specialty groups coming together to tackle an issue. But that same thing is happening in research, in large part because you want to make your research extremely novel. And so how do you do it? You do it by reaching out to the neurologist and saying, how do you view women's health in Alzheimer's disease, as an example, which is much more common in women than it is in men. And so how do you make it more novel? Well, we're focusing on the small vessels in the brain. And so we can focus on the small vessels elsewhere. So you look in different ways and bring different people together in order to provide new solutions to problems that, like you said, face you every day. And we look for pathways and overlapping pathways. And what you mean by a pathway is, for example, inflammation. Inflammation's not a good. You don't want it in your body, and it's a highly pro-disease development. And so those pathways follow cancer. They follow heart disease. They follow Alzheimer's disease. You name it. And so how do we find these overlapping pathways which can therefore underline disease mechanisms? And you say, oh man, she just talked like a lot of science stuff. What does that mean? Well, we can target anti-inflammatory agents that we have in order to control them. And there's all kinds of different inflammatory proteins, et cetera, but drugs impact specific ones. So if we know that, then we found a treatment for that. So that's the way you approach it today. You used to kind of be more blanket like 20 years ago, but now I think we're trying to be a little bit more sophisticated.
And it makes so much sense, right? Connecting those dots. Yeah. I think we're used to thinking that the brain does its thing and the heart does its thing and the uterus, that is completely separate or non-existent, as we know. And now finally we're trying to reorient our thinking. And even in pregnancy, we're starting to connect those dots between how our brains function, what our cardiovascular systems do. How does that show up, Dr. Stone?
Well, I think that, I want to say two things. One is what you said about obesity and inflammation is so important because we're seeing so much more chronic disease now, right? Yeah. And obesity is such a huge contributor to it.
So to speak.
Right?
Sorry, that was a joke.
What did you say? So to
speak. Huge contributor.
Yeah. And the inflammation that surrounds obesity, the increased risk for hypertension, cardiovascular, that's a huge thing that we should be tackling, like on a national, really international level, because I've heard you say this before, even in Asia, where they generally have a low BMI, body mass index, now theirs are going higher as well. So countries that never experienced obesity are experiencing it. To get to your question, I think, pregnancy, there's a concept, pregnancy is a window into women's health, and we know that that's the case, right? So we know that what happens in utero, if I mentioned a growth-restricted fetus, that fetus is programmed in utero to try to save its nutrition. So it comes out, so it changes its whole pathway. And when a baby's born who was growth-restricted, it has a much higher risk for then developing obesity later in life, developing diabetes, developing hypertension and cardiovascular disease. And for women who had a growth-restricted fetus, or who developed high blood pressure during pregnancy, what we call preeclampsia, or had a spontaneous preterm birth, we also know that many of these factors are linked to an increased risk for diabetes as well as cardiovascular disease.
It's really fascinating when you talk about pregnancy being a window to the future of a woman's life. I mean, I've heard that, 20 years, but it always made sense. But you never really had a lot of evidence to really understand the connections. And now, more than ever, we see that it's 9 million% true, right? And yet, there's not a healthcare system in the world that brings that information to middle-aged and elderly women. That's left in the past. And it is such a crime because that information can be invaluable. I mean, as you said, these women are have a predilection for obesity, diabetes, type 2 diabetes, hypertension, and you can predict it at age 20. And there have to be, particularly a woman who's preeclamptic is going to have a daughter who's preeclamptic, is going to have a granddaughter who's preeclamptic. We have to understand the genetics of that totally. And yet so much of genetic research is really at its infancy in terms of bringing that evidence to clinical care. You know what I mean? It's not just, there's a ton of genetic research ongoing, but we don't have tools that either of you could use like tomorrow. And that's where I think we're really stuck. In addition, we could really target some of these women who are at high risk of gaining 90 pounds during pregnancy, and try to talk about really intensive lifestyle changes. Try to find pathways to put them on a better course for their health and maintaining. As I've done a lot of research in older adults. And to get a 60-year-old to change their preventive life, it's not going to happen. They just won't. It's just too hard. I've worked on 3 different trials. The trials are well over $200 million, and we failed miserably in getting adults to lose weight. We have to maintain healthy weight and healthy lifestyles at age 20, because then it's going to be a healthy lifestyle at 30 and 40, et cetera. And that research is fundamental to maintaining a healthy population.
Well, Leslee, I wish you were around when I was pregnant because I gained 80 pounds with my first pregnancy, and I actually don't know how much I gained with the second because by the time I hit 80, I refused to be weighed, which is not something I would recommend, by the way. Your weight gain in pregnancy is a window to your health in pregnancy, too. On a more serious note, I think, again, we're going back to that same point. Women's health pre-pregnancy, women's health during pregnancy, and women's health after pregnancy should really matter. We're not even doing enough to identify these risk factors that could change her health during pregnancy and the outcome of that pregnancy, including the child's long-term health, let alone care about the woman's health after the pregnancy. So I think, it's a real call to redefine what do we even think of when we say women's health. It's much more than fertility. It's much more than reproduction. It's our physiology that allows for those events actually had such wide-ranging effects on all of our health.
Yeah, and I also think one of the big questions, for me at least, is like, why do people act so differently who are going through the same situation? So we mentioned you gained 80 pounds. I have a current patient who's gained, probably 90 pounds. She doesn't have diabetes. She doesn't have thyroid disease. We had to meet with nutrition. She's not eating like crazy. She is doing whatever exercise she can do with having gained like 90 pounds. But why? And I don't have an answer to that. Why is it that some people, when I went through menopause, I had no symptoms whatsoever. Why is that? And other people are experiencing like incredible symptoms.
I see it every day, when the weight question, which is really a cardiometabolic question, is so salient, especially during midlife. Why do some women barely gain anything and some women gain 30 to 50 pounds in a span of 10 years, with most of that weight gain being around their middle, which is really not where you want to have the weight? And many of them are doing everything they should. They're, really careful about how they're eating. They're exercising. They have difficulty losing the weight. And even with the newer medications for weight loss, there's such variability in how sensitive people are. And maybe Leslee, you could tell us a little bit about it. I actually don't know the answer to this question. When studies are done towards approval of medications, how careful are we in terms of differentiating male physiology from female physiology and the response to new drugs and therapeutics?
Well, like the GLP-1s, you've never seen a secondary analysis. That's what it's called when you report the main results in a trial. In the secondary analysis, so like that would be looking at specific subgroups, diabetics, et cetera. You've never seen them reported by sex.
That's incredible.
That's
That
incredible.
is wild.
And the reason I know that is
Shocking, my favorite word on this podcast.
Shocking. But I tried to look for it because I was doing a presentation, and even the more recent SELECT trial. I actually wrote a letter to the editor to the New England Journal that got published, complaining because it had 26% enrollment of women. Now, I'm sorry, there's a higher prevalence of obesity in women. So how can this be tolerated? And I could go on, but we have to have regulatory oversight. FDA has to play a role in ensuring. Investigators are going to say it's hard to enroll women. They're going to say that. FDA has to say tough, right?
Why is it hard to enroll women?
Well, it's more complex. If it's the trial, women earn less than men generally, so you'd want to incentivize them financially to offset that. They may not have money to take a bus, extra money. And we're talking about extra money to take a bus. They may have to, if they left their work, they may have to have lunch. We don't, in many cases, historically provide zero support for the patient. And then do we have child care for somebody who's going to come for a clinic visit? The answer to that is no. Do they have other responsibilities, even if it's an older woman? Is she caring for her grandchildren? This makes it complex. I think one of the things at Sinai that has really helped us is that our ethical oversight now allows us to provide support for patients. And you really are able to achieve much more equity in enrollment, but you have to understand the needs of women. They're not just the other half of the population that looks like men. They have different, unique issues. And it's crazy that it's taken us 20, 30 years to convince people, because I can tell you the difference between enrollment, if I provide some modicum of support to get them here through Uber or whatever, plus lunch, plus if they have to have childcare, it's night and day. Why isn't that just the biggest no-brainer?
I think that social context is so important, and even though I tend now to see somewhat older women, caregiver burden is a massive issue, whether that is your children or elder relatives. The statistic, I think, is something like 70% of all caregiving is done by women, and it's often not compensated. I can totally see how impractical it would be to have to go for a blood draw or show up to an appointment, all of that. What about in obstetrics? There is also this idea that women were not included in trials on purpose because we wanted to protect women just in case they got pregnant. And my understanding is that that is also why we simply don't have information about, for example, the real safety or harm of many medications in pregnancy.
Yeah, for many years I sat on the Institutional Review Board, which reviews a lot of the research applications, and it always drove me crazy that pregnant women are considered a vulnerable population.
Along with prisoners.
Along with prisoners, exactly. I was just going to say that. So prisoners and pregnant women. It's really it's quite insulting actually to categorize a pregnant woman as being vulnerable, like they don't have the intellectual capability to make decisions regarding trial enrollment, things like that. I think there's one piece. The pharmaceutical companies don't really want to enroll women in studies that have the potential, like what if it has some downstream effect on the fetus? Okay, I sort of understand that, right? But on the other hand, it's so important to not exclude pregnant women in so many different trials that can really affect outcomes. How can we know, if something is safe during pregnancy? How can we improve conditions if we don't enroll them in trials? And I agree with you. I think besides, taking care of children, if they already have children, taking care of older parents, they're also the ones that are cooking the dinner, shopping, paying the bills. I mean, well, speaking from personal experience, but making sure that everybody's taken care of, and that the housekeeper is coming in time, or whatever you're doing, and it leaves very little time for them to maybe join clinical trials.
I mean, to add something like a clinical trial to my to-do list, which, by the way, I've renamed my to-do list. It's a wish list, really, because I never get to the end of it, right? And that's probably goes for all of us. So how do you then deal, as an maternal fetal medicine specialist, when you're in those shoes or wearing that hat of your 100 hats, how do you deal with that uncertainty? Because that's how it shows up. If you have no data about the safety or harm in pregnancy, I mean, that creates a really difficult situation about how to counsel a patient and help her out.
Yeah, it's a huge problem because we just don't have enough information. I mean, there are certain things that are done well, right? So we know that if you're in labor and you've broken your water and you need to have a cesarean because you're not progressing in labor or there's an emergency, whatever. There are trials that show us that adding another antibiotic, azithromycin, to the typical Keflex is going to decrease the rate of infection. So there are some things that are out there that are done very well. There are a lot of trials regarding induction of labor that we know it can improve outcome. But there are so many other things that we have absolutely no clue. I mean, why does somebody who we measure the cervix routinely around 20 weeks as a sort of risk factor for developing spontaneous preterm labor. Well, somebody with a cervical length of 1 centimeter, which is super short, anything under 2.5 we consider low. Why does that one person go on and have a totally full-term pregnancy while the other person can go on and dilate and actually lose the pregnancy 2 weeks later? We don't know. Like, we don't understand that pathophysiology of the cervix and how that is different in different women.
Yeah. It really this gap in knowledge really shows up in so many ways, and I think you guys have done an amazing job of kind of delineating the reasons for that. Reduced participation of women in clinical trials by design or by just what women face every day. Lack of funding, this idea of protectionism, some limits of scientific inquiry that I think we all have to accept because we're definitely going to know more 50 years from now than today. But so Dr. Shaw, you tell us, like, what can we do? What can women do in general? What can somebody do who is not a researcher, who's not a clinician? What are some ways of supporting our sort of scientific discovery?
I think it's a culture, right? It's a culture of valuing knowledge and valuing your clinicians who taking care of you, and it becomes more important the older you get, because your proclivity for not just one disorder but multiple disorders increases quite dramatically. By the time you're 70, I think most Americans have 3-4 different chronic diseases, and it's not unusual for them to have 5 and 6 chronic diseases. You want to have the clinicians that have the most knowledge. So ask them, how their knowledge is. And, you want to understand where there are research. If you have questions of your own, look on the internet to see if there are ongoing studies that you could participate in. Most academic centers, but mostly Sinai, no, just kidding, would welcome you. And, I think that you can find a lot of this information online, participate, give feedback. It's really important as a scientist. I love to have patients that want to give me feedback. I take advice from anyone, and it's important for in my perspective as a scientist, Research is only important if it changes lives. And so if you have a burning question, try to find out if there's some way that you could volunteer. Or if you find a clinician that's doing a little bit of research, see how you can help them. Of course, you can always write checks. That's important, particularly when the NIH money is at a scarcity. But I think that it would be wonderful to see women rise up like they did for breast cancer. And rise up to create a very knowledgeable healthcare system that understands menopause, that understands pregnancy, and really brings that state-of-the-art strategy of care, because it is a strategy. I mean, I think one of the challenges, if you looked at drug A versus drug B, you mentioned, adding Keflix or some antibiotic to second. That's a typical randomized trial. But most of what we're talking about in women's healthcare is a strategy. It's not just one drug. You can see that it's effective. But though, if you just look at drug A versus drug B, you don't really know a lot about how to use it. And so we need to really have research that meets that needs, which brings in, the endocrinologist, brings in all these and develops strategies of care that can really meet the core needs, particularly, I think, of the older woman, the woman going through menopause, who has multiple things going on and is soon to have multiple disorders and multiple diagnoses. And that's just Western society and how it is right now.
I have to ask you this question. Here I hear my kids saying, "Oh, here comes Mom with her favorite question about anything." How do you think artificial intelligence will change things?
Well, the challenge is, I know you're a super enthusiast about it, is you still need, there are technical terms in AI, you still need a human in the loop. That's actually a technical term.
I kind of love that term.
And, because it makes mistakes. I was part of a recent large FDA meeting that I had in September in Washington, because the AI software makes a lot of mistakes. So in this case, it was calling a lot of patients having atherosclerotic plaque or heart disease much more than what a clinician would say. So if you go from having a prevalence of disease of 50% of the population to 95%, that's overcalling. And so these AI programs are overly sensitive, and they have to be they have to have oversight. So is it I think there are certain things that prioritizing acuity of care, things like that, I think are important, but it's going to make mistakes. There are people that predict a radiologist won't read a mammogram in 5 years. Now, come on now. I don't want a machine reading my mammogram. I think it has a way to go. There's too much hype. There's too much venture capital in it, and focusing on ROI, return on investment, and not on practical issues like quality of care. I'm on a scientific advisory board for a couple of companies, and I had one meeting with them last Monday at 8 o'clock at night because they're in San Francisco. And they're like trying to do all this stuff. I said, just get what you're trying to do correct. Don't try to focus on overhype. Just provide a product that is accurate. And I think in part of the problem with AI, and this is why one of our colleagues, Eugenia Oliva, is so invaluable because she's a physician.
We have to have her on this podcast.
Yeah.
That presentation was just fascinating.
But she's a rarity. How can you have like a PhD in computer science that knows nothing about medicine actually be writing algorithms that are so overhyped and become worth $1 billion? It doesn't add up with what we know about medicine. So it's fantastic, and we have a lot of examples. The ECG, just the electrocardiogram, has been there have been machine learning algorithms in interpreting that for 20, 30 years. So there's a lot of examples that it's great, but we still need that human in the loop.
Yeah, AI is not going to be delivering babies, so I'm happy that there's a human there that's still in the loop delivering
there's
that baby.
going to be definitely a human in the loop.
Yeah, I don't know. Maybe there will be robots delivering babies. I don't know. They're delivering Amazon packages. They could deliver babies.
Thank you both so much. All right. This is the question I've been waiting to ask. let's say it's 50 years from now. You close your eyes and it's 2075. What is the answer you would wait the most for? What are you most excited to know in women's health that you think will be answered by then?
That's such a hard one. There's so many things I can think of, but I think for me, probably understanding labor, which we don't understand why labor starts, and preterm labor, why preterm labor starts. I mean, there's a lot of different mechanisms that we know are involved in it, but we don't really understand it. So I think understanding the onset of labor, what we call parturition, whether it's normal or abnormal, to me would be amazing.
I second that. Having been in those shoes and having to answer the question, why did this happen to someone who delivered early, and just saying, we have no idea, I think that would be really revolutionary. Dr. Shaw, what about you?
By 2050, which, 25 years from now, something like that, the U.S. population, over 60% of the U.S. population is supposed to be obese. And that means in healthcare, we'll probably see about 80% because it's always higher. You get that selection of what you see. And you can see that if you go around the world. You can see the prevalence of obesity just skyrocketing. It's not a pretty sight for us. It would be great if we break that cycle early. And I'm not just talking about in the United States. I'm talking about wherever we go. Brazil, you see urbanization is brought with it, poor diets and obesity. China, I was just in India last week, and you see skyrocketing rates. It'd be great if we could keep people healthy. I think that's the key. Not that we are focusing on intervention, is we keep them healthy from childhood through adulthood. Just the wear and tear on your body in general, and then you throw other things like hypertension, diabetes, and obesity. If we could do that, and we could learn how to do that for Africa, we could learn how to do that for South America and all of the other countries that seem to emulate our poor behaviors, that would just be awesome.
I love that too. In education, empowerment, prevention, rather than just reactive treatment. 2075 is going to be great. That happens.
Awesome.
Thank you both so much, Dr. Stone and Dr. Shaw. It was my pleasure to play host for today. That's it for this episode of HERology. I'm your host for today, Dr. Anna Barbieri. And for more groundbreaking conversations about women's health, please find us on YouTube, Apple Podcast, or Spotify, or wherever you get your podcasts. HERology is a production of Mount Sinai Health System and the Carolyn Rowan Center for Women's Health and Wellness. And to learn more about the amazing Rowan Center and our state-of-the-art facilities helping shape the future of women's health, please scan the QR code on the screen or click the link below.